Good morning, dear friends and colleagues. I'm honored to present this talk about hip arthrodiastasis using a reserve technique, step by step. I'm Mohamed Fadel from Al University Hospital and honorary president of LRS unit and LRS program director. Uh, Affiliated to many national and international associations, and happy to be in the early morning to start this virtual day of the LRS course in orthoplastic skills, which we fall tomorrow, Friday, by 5 sessions of workshops in Arabic Institute in Al Muqattam. We will not talk about the Perths disease or other principles, why, when, and how, but we will go directly to the hip arthrodisthesis and explaining the Elizarov technique step by step. I am interested actually for Perths disease long time ago, since 1999. About 25 years ago, we started working in Elizarov as a sort of management of Perths diseases and resulted in some publication with my dear friends and colleagues, Professors Gamal Hosni, Khamis Dib, and Mohamed Lakluk. And this gave us a chance to present some papers. Also, even non-Elizarov papers such as that one with Professor Khamis Dib about late results of modified sutures and nominated osteotomy in the treatment of Perths disease. Arthrodisthesis is a distraction through a joints, so it is not only belongs to hip joint only, but also may be used in some cases of knee or elbow and in cases of ankle also. The concept of hip arthrodisthesis and the hip distraction or distraction histogenesis unloads the joints and negate the harmful effect of stresses along the articular surface. So this give us the chance to have sound healing of the area of necrosis and disrupt and interrupt this vicious circle in this area by applying the Elizarov at this point. The Elizarov tension stress and the distraction histogenesis may have the microvascular effect and also even a mechanical effect of flooding, and also in some instances a containment method to safeguard against the late bad outcome of Perths disease. So again, we will leave the demographic distribution, definition, and differential diagnosis, and go for an example of using Elizarov in a case of Perths disease. Our aim is to present a technique that prevents the long-term complications and drawbacks of using distraction or arthrodiastasis technique in Perths disease. Preoperative notes of hip arthrodisthesis may be presented to make it easy to understand well the technique, which related to fixator type, hinge or non-hinge technique, extension rod, adjunctive procedures, pens placement, and hip positioning. The fixator type may be monolateral external fixator or circular one, or Taylor special frame, which has not had been used at all yet. The distraction technique may we use a hinged fixator, and in this case we can use it articulated either monolateral or using Elizarov technique with a hinge also. Sometimes in using hinge, we should rely upon that the center of rotation of the hip should be parallel or collinear with the hinge placement, either in a monolateral or in such cases to have a free movement, flexion, extension, or even in cases of Elizarov to have a flexion or extension movement freely with no obstruction. Sometimes in some conditions we use non-hinged fixture. We did it also, non-hinged technique, either using monolateral or Elizarov also. Extension rods had been treated by some authors, though I prefer to use and lock the hinge instead of using extension block or extension rod. Adjunctive procedures such as soft tissue release had been used and adopted by some authors, and others didn't do it. And also epiphyseal drilling had been adopted by some authors. Pins placement, either be pelvic or femoral. Pelvic may be suprastapler only, and may be super added by a pelvic rods, pelvic pins also, or Schanz pins, and the femoral may be the femoral shaft itself, or this area of subtrochanteric area also in the femur, according to the size and the preference of the surgeon. The position of the hip while applying Elizarov and throughout the movement is the position of containment of the head, which is some sort of abduction and a slight flexion. The hip positioning on the table, we should be in our mind that it is already inherited, that on lying supine, the patient may be in a case of hyperextension or at least 180-degree extension, at least, or zero extension. So we should put in our mind it is not reduced in this condition. We should rely upon that some sort of flexion and abduction as this position. As we will see here, containment is so important during all over the work of our distraction, hysteresis, or arthrodiastasis. Looking for what had been presented, I hope that we presented some mandatory topics about fixture type, hinge or not hinge, extension rod, adjunctive procedures, pins placement of a position. Now we are going for an operative technique, which I will try to discuss the combined saw bones, radiological, and a life surgery in the same manner by presenting a pin placement, construct components, assembly, application, and at last is a test of hinge functioning. The patient lied and have the position either in the lateral side or supine on the traction table or in the conventional orthopedic table. The arches had been used, one femoral and one suprastabular, such as this, or two arches femoral and two arches femoral and two arches suprastabular, and maybe pelvic also. The arches pre-assembly, which looks closely in this plastic model or saw-bone model, it is clear here, and the assembly here also is clear that after application of the connection rods. So the free assembly is clearly summarized as one femoral and one acetabular, and maybe two femoral and two suprastabular. We're using some pins in the femoral and the pelvic, at least two chans on each sides of the distraction. Pin placement is as usual done. We will make an incision and apply the chans by the blunt end of the chans to touch the bone and have a photo in the image intensifier, and then application of a small incision by the scalpel, then application of the drill point, and after drilling we can apply the shafts by screwing it, not by using the drill power. Using this technique is so important in the suprastapler area and in if we are using the pelvic ring. In the other hand, we can use the motor power in the femoral area by also application of the wire, not the pin. The wire first to touch the bone, and after the wire touches the bone, we can drill by using the electric power. So the same technique will be applied here, suprastapular, as we can find here. Here there is one chance, and parallel to it another chance, and super added to them, superior for them, a chance. So we have three chances suprastapular in proximal to this arch, and for this arch we have here proximal chance or two and distal chance or two in different levels by using the same technique. This is the final technique in the image intensifier before getting out of the operating room. The connection, as we discussed before, non-hinged or hinged extension rod here, we can use it through the hinged apparatus, as we will show it. In this case, this is a case of non-hinged technique. We can find that no need for doing a hinge here in front of the hip joint center of rotation, and here also no need. We can lock the ball and socket joint here to have it without hinging effect, and if we hinge use, we should have the hinge parallel or collinear to the range of motion of the hip joint. Also, if using the Elizarov, we should have the center of rotation or the hinge of the apparatus of the Elizarov parallel or collinear with the center of rotation of the hip joints, and we should maintain the containment all over the process of the management. There is two techniques, either to pre-construct or to use the mounting the construct on top of the hinge position. In all instances, we are in need for main accessories. The steps of hinge construct, which is the main and important unit of the arthrodiastasis, is this just female hinge with threaded rods, nut, nylon nut, and bolt. Then application of one unit, a threaded rod with female nut, female hinge, and application the same thing here to have both units. Then connecting those with each other by using a bolt, as we hear, it's clear. Then application of the nut, as we will see here. Then we have two types of hinge working by the same configuration. Two hinges have the same configuration to be used as a mobile or as a straight one, as we will see here. Here as it is a mobile one, and here as it is straight one. This mobile one help us in range of motion all over the process of the management, and this one will give us the standing or distraction without movement at all, and works as an extension stop or preventing extension of the apparatus of the procedures. So the frame components, as we mentioned, one arch above or proximal, one arch suprastapular, one arch femoral, two arches suprastapular, two arches femoral, as here it is clear here, and here we can see that it is here it is more that it is how it is could be constructed here, and also here we can notice that if we apply it in the flexion, some sort of flexion and abduction, we will have free movement. The connection in this configuration, no need for extension rod, as we can use the hinge as extension rod by application and tightening it. This traction could be done or applied in intraoperative on table to have 4 up to 5 millimeter traction over correction of the Shenton line. And now we can find that we can complete our procedures as a workshop and as intraoperative procedures, except the testing of the hinge function live. So intraoperative, we should do it. We did it before in the sawbone model, but actually we have on table in the operating room. This is a condition inflection, and this is a condition extension. It is very nice and good to have this, and this we can find that the collinear hinge, which both are collinear with the hip joint movement, and we have here the multi-axial shands, two and one here and another one here, proximal and the distal to the femoral shands, and also three shands up, and all this constituent is the multi-axial by hinge, multi-axial, multi-level configuration of Elizarov apparatus, and we find here how it is have full flexion, full extension, and should have interoperatively what is we'll see here in this. So we can use this after tightening as extension stop or as support for the patient to prevent pain post-operatively. This is give us the chance to give this schedule as double hinged here, multi-axial, more than one axis, and the multi-level fixation. Thank you. This is the cause of success.